Today I'm going to talk about current classification and progression display for keratoconus. Well, prior to this present classification, there have been many studies, publications about the grading system for keratoconus. But all these grading systems done prior were main, sorry, yeah. So all these grading systems done prior mainly banked on the anterior corneal curvature. With the changing times, with modern technological advancement in imaging cornea, with Scheimpflug imaging techniques of tomography and optical coherence tomography, and also with the advancement of treatment modalities, these grading systems probably will not suit to the present era. These all these mostly like they banked on the anterior corneal curvature. Definitely Kmax and the other parameters play a paramount importance. But with the changing times, when we are able to uh, know all the layers of the cornea, recognize all the layers of the cornea, and we can detect early and subclinical stages at the very infancy, why not adapt and take the good from the modern technology? So, well, this new classification banked on this parameter, the posterior elevation, and they have graded, uh, called Bellon's ABCD grading keratoconus staging and display. Now, do we really need this grading system? I would definitely say yes, because as I've said, the prior grading system, especially the Amsler Krumak, which has been widely accepted even now, is a 70-year-old grading system. And what does the new way of diagnosis for keratoconus um, outline? The study, which I had shown previously, clearly outlines the parameter of posterior elevation as one of the most important abnormality that can be picked up very early. So this is the parameter what the ABCD wanted to highlight and bring into notice so that we pick up cases at the very infancy. And because there is also the modality of treatment like collagen cross-linking that has been developed, we can prevent progression of the disease and do not wait for the progression or change in the Kmax to uh, apply treatment, but rather even before we have a progression or a drop in vision of a 1-2 line, we would like to treat the disease. So definitely prevention is better than cure. The study also outlined that the newer techniques of diagnosis of keratoconus play a very important role. Again, for the subclinical uh, keratoconus, the diagnosis emphasizes posterior corneal elevation abnormalities. Taking all this into consideration, the study did that investigation. Well, a word about Amsler Krumak classification and its limitation. Though it is a 70-year-old classification, it is appreciable that even today, most of many people are using this classification. It has many limitations because this classification was developed way uh, like in 1940s. It's a 70-year-old classification when the machine used was an keratometer, and for thickness they used optical pachymeter. But now when we have tomography imaging, why not have a better grading system? So, and also it relied mainly on the apical thickness. Here again, let me tell you that keratoconus is not just cones in the apex of the corneas. We know that the cones, keratoconic cones, are seen in the temporal areas of the corneas as well. So there are high chances of missing the cones. It does not take into account the posterior surface, and also there's a element of confusion in staging. Suppose a patient comes with these parameters, how do we grade the patient? Is it stage 1, stage 2, or stage 3? There is a confusion, and this confusion is very well tackled by ABCD classification, because this classification banked on not just the thinnest point, but it took into consideration a 3 mm zone around the thinnest point, and also it dealt with recognizing all the 3 anatomical layers: the anterior corneal curvature, the thickness, and the posterior corneal curvature. And it's very easy to interpret and no confusion as well. Now, what is the goal of ABCD? The idea with which this was developed was to prevent progression and to pick up keratoconus at its infancy in subclinical stage, so that we implement treatment right at the right time and prevent any progression. So definitely it's to look beyond Kmax, and it is easy to interpret, and not just on looking at the progression. By looking at the grading system, we can even evaluate what type of treatment we can implement for that patient. What do ABCD define? A is the anterior radius of curvature from a 3 mm zone centered on the thinnest point. B is the back radius of curvature from a 3 mm zone centered on the thinnest point. C is the minimal corneal thickness, and D is the best spectacle corrected visual acuity. Now, this is the new Bellin ABCD grading system. As I've told you, they have incorporated all the four parameters which I've discussed: the anterior radius of curvature, posterior radius of curvature, the pachymetry, and the best corrected distant visual acuity. And the advantage of the system here is they included grade 0, which was lacking in the previous classification. Here, the normal people can fall into this criteria, into this group, whereas the normal population were graded as grade 1 keratoconus in the AK classification. Now, this is the topometric maps, what the machine, when we designate, we can procure from the machine pentacam, and it clearly gives us an idea of this grading system in the machine, along with the axial maps, anterior and the posterior, and of course the normal Kmax and R parameters, which we are very much acclimatized to and which we are aware of. Just to magnify and make things clearer, now this is the case, this is how the grading system comes up in the machine. Now, this is normal. The right away, even the look of it, we can diagnose that this is a normal eye. We do not see any kind, the same 4 parameters have been designated here, and the grade 0, 0, 1, 2, 3, 4 are designated horizontally. And now when you see this, there's no element of any parameter that is progressive. So that is normal. So it is a graphical display on the right side. Down is the grouping, just like the breast cancer or any tumor grading. They have graded keratoconus. Sorry, A is the anterior radius of curvature, B is the posterior or the back radius of curvature, C represents the thickness, and D is the distant visual acuity. Here are the parameters more accurate and more specific, so we can bank on this with the distant visual acuity and so on. So just by looking at it, we can know the severity of keratoconus. If you see here, the progression of the anterior elevation or the anterior curvature is way progressing. The posterior again is way progressing. Thinness is fairly decent, but then we have this visual acuity that is again falling short of. There is a drop. So it's moderately advanced. And when we see the advanced parameters, the graphical display, it is all the parameters are progressed and they're past grade 3. And here are the parameters, and the vision drop is 20/100. So by looking at this, I feel definitely this will be a time saver for us in our busy clinical practice in the OPDs, outpatient departments, and also it gives us an idea as to what modality of management the patient can fall into. Definitely, we don't bank totally on the machine, but we apply these to the um, clinical findings of the patient and would uh, plan a treatment modality plan. For example, in this case, I would definitely consider a cross-linkage, collagen cross-linking, even before I want any change in the anterior curvature, wait for the anterior curvature to change and a drop in the vision. I would not wait for that, but would definitely subject the patient to collagen cross-linking. And in this case, probably we can use a combined, and definitely the age makes a difference, considering the age. We can apply collagen cross-linking with probably intrastromal corneal rings. And here, definitely, probably a surgical modality of DALT we might think of. This is again just to familiarize with the grading system. If we all see these are the early stages of keratoconus, the map itself will just give us a fair idea, and the grouping A1, B2, C1, D1 will tell us that it is an early keratoconus. And this again, if we just correlate this grading system with the axial map anterior, and we see a cone here, a keratoconic cone, and we definitely know that, and the big posterior progression abnormality. So this would definitely fall into a moderate, advanced keratoconus. And this, the graphical display and the parameters and the grouping, and look at the big dense keratoconic cone here, which correlates exactly with the graphical display displayed here. So that is the importance of the staging. Now you can pose a question: when already we have an ABCD grading, why do we need a progression display? It gives us an idea for progression. It does, but it is not specific, which I'm going to talk about. Now, the ectasia, again, we change with the changing times. We change the diagnosis, the definitions of the diagnosis of keratoconus are changing. The ectasia progression is banking on all these parameters. And if you see that, definitely, again, they included a steepening of the posterior corneal curvature. So the ABCD progression display answers this and takes into consideration all the layers of the cornea. Now, I would definitely not negate all the prior progression parameters, which give us so much of idea, and we've been using it and we still will use it. But then all these parameters deal with the anterior corneal curvature changes, except probably the pachymetry that does not define anterior corneal curvature. But definitely they do have value, and we're not going to neglect these, but taken posterior corneal elevation as our paramount factor for the approach of treatment of keratoconus. Now, I want to specify here that we again had a beautiful refractive screening display done prior, the Bellin-Ambrosio display. This was a great screening refractive tool, very simple to read, and the color coordination helps us just to identify it at a glance. If you guys, if we remember, just a recap on what the bad display tells us, it displays all the D values, the final D here, and the color itself will give us an idea whether this is an abnormal or a normal cornea. The yellow signify a deviation of 1.6 standard deviation from the norm. The red signifies a 2.6 standard deviation from the norm. And the final D, if we see any abnormality, that would definitely give a clue that whether this is an early subclinical case of keratoconus. Yes, it does give us a lot of information. For example, this picture, if you see, These are the standard maps. These are the enhanced elevation maps. These are the difference maps. And in cases of subclinical cases, we see all the anterior parameters are normal. But if you see the posterior elevation map, the standard map just defines a small cone here, and which is accentuated here because of the enhanced map. And here again, it is enhanced. But to make a point clear, and of course, these are the progression maps, we can gather a lot of information and the progression index. So we gather a lot of information from these maps, but then they just want to make a point clear that bad display definitely will give us an idea whether it is a subclinical or an early keratoconus. But the idea of bad display was only to differentiate between a normal and abnormal, not specific for keratoconic cones, because we see in cases of hyperopic LASIK, the D value changes. In cases of an endothelial dysfunction, the D value is abnormal. In cases of a post-refractive, the D value might change. So the final D is not very specific to say that these are cases of early or subclinical keratoconus. So that is the reason we do not bank on the bad display or ABCD grading. Though bad display, I have already explained, it's not very accurate to pick up the keratoconic cones. Again, ABCD fairly gives us an idea regarding the progression and the severity, but this is a population-based study and it does not confine to a single patient. So it's now, again, not very specific. Coming to the progression display, it's based on all the tomographic layers. It picks up early cases, early implementation of treatment, and at a glance, it compares the baseline with the consecutive visits and documents statistically the significant change and, if true, progression. This is the publication of the Dr. Bellin and team. The progression display pictures, what I'm going to talk about is being taken from. Okay, this is the progression display. This is the display one, which I don't want to talk about. And this is the progression display two. So I just want to point out that they again took ABCD as the parameters. And these are the 8 visits, the maximum 8 visits, which we can document. The first visit, the first visit of anterior radius of curvature, the first visit of the posterior, the thickness, and D. And if you see that these are the confidence intervals of 80% and 95% confidence intervals, which we take. If these patterns go forward or proceed beyond this, definitely there's an abnormality. And also the keratoconus treatment is given, like the collagen cross-linking is by the hatched line. And after the treatment, these drop because further studies are underway. And again, we already have a tabular form of the previous parameters, which are also incorporated in these display maps. Now, because of lack of time, probably I'll skip all this, but I want to say that they have taken normal and abnormal patients into criteria of keratoconic patients to describe those gaits, which I was talking about, the green and the red gaits, which I was talking about. And this normal gaits would correlate to the patients of early and subclinical cases. That's why they even took the normal population. And keratoconic population, the patients of more age, the age is more or advanced keratoconus would correlate with the keratoconic population. So just want to get an idea. See, for example, in subclinical keratoconus, look at this beautiful display. All the anterior parameters are stable. Nothing is passing beyond the 80% confidence interval or even the 90% confidence interval, 95% confidence interval of the keratoconic. But if you see the posterior corneal elevation, it's way past even the keratoconic group and the normal population of the 80% confidence interval. And here the keratoconic, the normal population, 95% confidence interval of normal population. So it clearly gives an idea of the progression. So one more example, look at this. All the anterior parameters are way past the confidence intervals. The posterior corneal parameters are way past the confidence intervals, and the thickness also has thinned down. This is a user operated, so it's not fed in, so it does not matter. These three are machine operated. A take home message is look beyond Kmax, detect early, treat early, and ABCD definitely is the answer. Thank you so much.